I have two books here, Let Me Decide by Dr. William Malloy, The Healthcare Directive That Speaks for You When You Can't. So this is a book about the living will. And I also have You're Living Well, Why, When, and How to Write One by Eileen Flynn. So these are two resource books that you might like to look at after the seminar, but they are books that are published in the States, and that's where the information's from, so it's certainly a little different than the laws in Canada, so bear that in mind. Kenyon has a whole bunch of information on the table back there. Do take some when you go, and if you'd like to learn a little bit more about Hospice Nelson, we have our brochures and newsletters, a little bit about our volunteer training this year, and the application form if anyone would like to become a volunteer. So that's about all I have to say. So we'll just start the presentation with Dr. Reid.
I have a prepared spiel that I will give to you, and a lot of this information may be known to you, but hopefully towards the end of my talk we can deal with some specific aspects of making a living will, and that might be an appropriate time for questions. First, I'd like to just sort of establish some baselines. What is a living will, and why are we interested in living wills these days? And then go through some clinical scenarios about where would they become appropriate, and give you some examples. I work as an internist at the hospital, and some of our most difficult times as doctors is dealing with patients who are dying and no one has thought about the dying process, neither the family nor the patient. And when someone's critically ill, that's not the time to start to begin to think about the dying process, because people are usually emotional, they're confused, and it's very difficult for people to make rational decisions. So that's why I think it's appropriate that people start to think about the living will at any time in life, whether they're young or old. So let's start with what is a living will, and it's simply a document prepared by an individual to attempt to direct the course of future medical treatment. And it enables an individual to anticipate future medical situations and make decisions regarding medical treatment while they still have decision-making capacity. And that, the key thing there is a decision-making capacity, and that's called competence. And competence means simply that you are in the right mind to make decisions about your own health. It's a formal statement of how you want to be treated at the end of your life. So who needs it? Well, specifically, primarily people who are older, but in fact anyone can have a living will. And they become more appropriate for people as they approach the end of their life, because they begin to think about how they're going to die, and especially if they've been told they have a terminal disease. And at that point, people then begin to look at the various options and try to decide when they come to die, how they want to die. Now, the specific format's different, and we'll talk about those later. Why have living wills become necessary? Well, in the old days, parents and grandparents died at home, and treatment was pretty limited. There weren't antibiotics, and there wasn't a lot to offer. People died naturally. Today, the concept of natural death is a difficult one to determine, because we have technology that can keep people alive for any length of time, and people don't necessarily die naturally. So this has become a new moral and ethical issue of medical professions and the lay population. And so that's why it's become essentially a topical issue. The living will is a document which helps us in the wise use of medical technology. It enables an individual to be involved in decision-making process surrounding their care before a crisis evolves. As I mentioned before, statements made in times of stress are often not reliable. So they become popular because people fear losing control over their final stages of life. They're afraid that technology will take over, that doctors will not be aware of how they want to be treated, and that life support will be used at a time which may be inappropriate for them. That they may be in prolonged pain or suffering, or be mentally incapacitated and have no control over what happens in their final days. Part of the problem is that each individual has a different perspective on how and when they want to die, and what they consider a good quality of life. For some people, being confined to a wheelchair is unacceptable quality of life. For other people, if you're an artist or a musician, confined to a wheelchair is not a big issue, and they can have a perfectly acceptable quality of life. So our perspectives differ on when we want to abandon the struggle for life, the way we want to die, and the type of care we want to receive when we're dying or before we die. And everyone's reaction to disability is different. And the living will allows you to specify to your family and to your physicians what your feelings are on those issues. It puts the power back into the individual's hands, so they're allowed to guide events towards the end of their life. The other issue regarding the living will is that we've come to an area where, as we all know, healthcare expenditures are wildly out of control. 70 to 80% of your individual health care will be spent in the last year of your life. Some of that would be totally inappropriate, prolonging life in situations which may not be beneficial. And so living wills have become important from a financial point of view, especially in the United States, where people families can be left destitute, looking after a patient in the ICU who eventually dies, and the family's left paying the bill. So specific issues that relate to finances. There are some pros and cons of the living will, and once we get into the details of talking about the living will, they'll become clear. But one of the difficulties with the living will is that they sometimes can place pressure on a physician to stop treatment before it might be appropriate, before it's clear that all hope of recovery is lost. And this is especially true in cases where a short period of artificial life support might provide a period of time where a patient could recover and then live a normal life after that. So that's one of the things we have to watch when we're dealing with living wills. Living wills tend to simplify things, and especially in the old days, the living wills, and I mean 10 years ago, the living wills were very simplistic, and they simply made a generalized statement about what you wanted from life, and they were a bit poetic, but they didn't give us a lot of detail, and they simplified an issue it was anything but simple. And the living wills which are being turned out today are much more specific. They give patients many choices to take, different scenarios, and Mr. McGee has a copy of one of those, which I have a similar one, and we'll go through some of the different options that are available to people, and they're not simple. And what we're doing is taking people who may know nothing about a ventilator, saying, I never want to be put on a ventilator. Well, some people have never seen a ventilator, they've never been in an ICU, they don't know what it's like to be on a ventilator, so how can you say I never want to be on one ever? That's one of the problems. And we're asking people to make decisions about medical treatment which they have little or no knowledge about. What is the physician's role in this whole issue? Well, the physician's role is to respond to the patient, and when the patient comes and says, I want to make a living will, then it's part of our responsibility to sit down and to discuss the various issues. Especially, this is important in patients who are diagnosed as having terminal illness, whether it's cancer or AIDS or end-stage heart disease. It's important to go through with the patient what the various stages of illness are and what are the various possibilities that can occur. And this can help someone to design a living will which is appropriate for their illness. And all living wills have to be designed appropriate for your stage in life. Again, as I mentioned, patient statements made in the face of impending disaster are not very reliable. And so we like to make these, to make the living wills before people get sick. Okay, what I'd like to do is to go over a few cases which are fairly typical, but we can also make up other ones as things, or if people have cases that they want to pose to me, we can do that. The first one would be, is a 70-year-old woman who presents, she has a past history of heart disease and high blood pressure, diabetes. She rarely sees her doctor and she only takes her medication sporadically. So we have a woman who has an underlying medical illness, and on one day she's admitted to hospital with severe chest pain. And shortly after she's admitted, she has a cardiac arrest. And this is not an uncommon scenario. And At that time, she's just been admitted, so a cardiac arrest is called in the hospital, and everyone runs to her side, and we give her intravenous drugs, we pound on her chest, and we revive her, and often that works. In this case, the woman had been her heart had stopped for some period of time, and although it was revived, she remained unconscious, and she was put on a mechanical ventilator in our intensive care unit. She was given intravenous medications, and her blood pressure normalized, and she stabilized from a cardiorespiratory point of view, but she didn't respond and didn't wake up and was unconscious in a coma. As tends to happen in situations like this, people develop complications, and this woman went on to develop a pneumonia and was treated with antibiotics. Again, she was unable to breathe on her own, and she remained in a coma. Her daughter and son were informed of her condition, and they came to the hospital. And as often happens, there was a conflicting feeling amongst the family what should be done. The son felt that too much had been done already and that treatment should be stopped. The daughter wanted everything possible done. And so we were left in a situation where the family was unclear, the woman had left no instructions, and we were left holding the bag trying to do the best. The patient remained ventilated, and no changes were made to the therapy, and approximately 3 days later she developed unstable blood pressure, and despite quote-unquote heroic measures, she went on to die, and the family was left in conflict. Now we'll come back to talk about that case in a while, but I'll give you another one which is less of an acute illness. This is a 60-year-old male who was previously healthy, and he started developing some nausea, decreased appetite, and some abdominal pain, and his wife noticed that his eyes looked yellow. And again, this is a real-life situation, and he was admitted to hospital for investigations and was found as having cancer of the pancreas, which had spread to his liver. Now, this is an incurable condition, and basically people who have this diagnosis tend to live for somewhere anywhere from 1 to 5 years. Now, he decided, because he was 60 and otherwise healthy, that he wanted to go ahead with chemotherapy to try to prolong his life and to give him some good quality life. And he had some response, and a year later the chemotherapy had been finished, and he started to have more abdominal pain, and he started to lose weight. Somewhere in that period of time, he developed a fever and had a pneumonia. He was admitted to hospital and had intravenous antibiotics and recovered and went home. Over the next few months, he got generally weaker, losing weight, abdominal pain, and then he was found to be losing blood in his stool, and he developed a bleeding duodenal ulcer. And he was admitted to hospital and had blood transfusions, and he was offered the option of having surgery because this was a serious ulcer that wasn't going to stop bleeding by itself. And at that point, he discussed things with his family, and his quality of life had not been good in the last couple of months, although he'd had a good year after the chemotherapy had finished, and he decided to refuse surgery, and he continued to bleed internally and then died the next day. So those are two cases. One, a dramatic event where a woman has a sudden heart attack, loss of consciousness, and never regains consciousness and dies on a ventilator, and the other is a man who has an illness which gives him time and his family time to appreciate the illness. He is able to work through a number of complications, one being a pneumonia. He survives it, and then he goes on, has another complication, and then decides that enough is enough and he wants no further treatment. Family is in agreement, and he dies peaceably. In the first situation, everyone sort of loses in that situation. The patient dies, the daughter and the son are in conflict, the doctors don't have good direction, and no one was willing to remove this woman from artificial life support. Not a happy situation. In the second one, time is available, complications are dealt with, and the result is more favorable in terms of the family and the doctors. Again, the patient still dies, but it's dealt with in a better way. So those are two case scenarios. One of the reasons for discussing these is to show that decisions should be made through discussions with the family and with the patient and with the physician. In the second case, they were made, and in the first, they weren't. Ultimately, the patient's wishes should prevail as long as they're mentally competent. If a patient's no longer able to make decisions due to their illness or mental incapacity, then the decision-making should rest with the family, or alternatively with a proxy. And a proxy is another issue which we're going to discuss shortly, but this is a person who's well known to the patient or the family and who can, in the patient's absence of mental competence, be able to discuss with the doctors and the family what the patient would want if they were able to discuss it themselves. And a proxy is becoming a very important thing in addition to the living will, because the living will can't address every issue that's going to occur at the end of your life. Whereas a proxy will be able to discuss, a proxy who knows you well will be able to discuss with the doctors what you would want. So what I'm going to do at this point is I'm going to show you a couple of living wills. And I'm going to... Marie. Is what would probably be called an older style of living will. I'm going to just read it because this type of living will applies to the majority of the living wills that we see, and we don't see that many, but most of them take this form. And it's basically dated and addressed to these people at the top, and to any person to become responsible for my health. And then it goes on and it says, death is much a reality, birth, growth, maturity, and old age. It is one certainty of life. If the time comes when I can no longer take part in decisions for my future, let this statement stand as an expression of my wishes while I am still of sound mind. If the situation should arise where there is no reasonable expectation of my recovery from physical or mental disability, I request that I be allowed to die and not kept alive by artificial means or heroic measures. I do not fear death in itself as much as the indignities of deterioration, dependence, and hopeless pain. I therefore ask that medication be mercifully administered to me to alleviate suffering, even though that medication may hasten the moment of death. The request is made after careful consideration. I hope you who care for me will feel morally bound to follow this mandate. I recognize it appears to place a heavy responsibility upon you, but it is with the intention of relieving you of such responsibility and of placing it upon myself in accordance with my strong conviction that this statement is made. Not very specific, very general, and it does give us some information, but it leaves a lot of generalities. For instance, physical or mental disability may mean extremely different things to different people. For instance, as I mentioned before, there are many people now who have perfectly good quality of life even though they're a high quad, which means they have very little function from their neck downwards. But they live actually a very high quality of life. So this is a very general thing, and although it helps us, especially in a situation like the first case where the woman comes in and is in a coma and is clearly not having any recovery, this tells us that she doesn't want to be kept alive. The next generation of living will gets a little bit more specific. The preamble is very similar to the one which I just read, but in addition to that, they start to specify various things that you do or do not want should you become in a situation where you become mentally incompetent. Again, they talk about heroic measures, and at the end they say, in particular, I would like the following instructions carried out. And you can then talk about measures of artificial life support in the face of impending death that I specifically refuse. And this can be electrical or mechanical resuscitation of the heart when it's stopped, artificial feeding when I can't feed myself, or artificial respiration, or another specifying one. I would like to live out my last days at home rather than hospitals, and and I would transplant my organs if they're suitable. So it begins now to make some specific directions, and this is more useful to us as physicians. Proxy statement here is now that you designate a certain person who is going to take over decision making if you become incompetent, and there should be a space for another person should the first person be unavailable. So that becomes a little bit more useful from the medical point of view. And from here on in, the living wills become actually quite complex and take a lot of thought, and also probably the assistance of your family physician to complete. This one is out of the book that Marie just showed you, called Let Me Decide. And I've seen part of that book, and it actually is quite useful. It works through the living will process with you and helps you to work through this form, which I'm going to go through with you now. The one that Mr. McGee gave you is similar to mine, but it actually goes into more detail and lets you tick off various boxes. So the difference with this one is that it specifically says that this is only to be used if I'm unable to make any decisions myself. So that this should be never used in any other situation unless I'm mentally incompetent. And it then specifies proxies, or what they call advocates, first and second. And then it goes on from there. And this is where it gets tricky. So, again, what they do is they break this down into life-threatening illnesses, feeding, cardiac arrest. And then they talk about reversible and irreversible conditions in each one of these. Now, if you go back to the man with carcinoma of the pancreas, he had an irreversible cancer, but he was going to live 1 or 5 years. During that time, he developed reversible conditions, pneumonia, bleeding, stomach ulcer, and he might have developed other reversible conditions. Now, his irreversible condition was cancer of the pancreas. His reversible conditions were pneumonia or stomach bleeding. At this point, he would have sat down and he would have said, at the time of his diagnosis, well, if I get a pneumonia and I'm otherwise well, treat me and be aggressive because I'm otherwise well. So he would have put down here, if I have a reversible condition, I would want to be treated in an intensive way, for instance. Towards the end of his illness, when he had had pneumonia and he was losing weight and he was getting sicker, he would have changed this living will, and he would have said, if I have a reversible illness, don't treat it. I've had enough, I can't go on. If I have anything, even if it's reversible, I want to be treated in a palliative way, which means keep me comfortable, give me morphine, give me fluids, feed me if I can eat, and give me pain medications, but don't treat me with antibiotics or put me on a ventilator. So, in this situation, the living will changes from 1 year to the next in this man's condition. Now, he's been diagnosed with a terminal illness, and so his living will changes as time goes on. For most of us, we can make up a living will once, and unless we have a terminal illness, that living will is good for many, many years. Let's take another scenario. I'm a 33-year-old male, and I've made out a living will, which is very unusual, because most people who are healthy don't make out living wills. But let's say I did make one out, and I had a car accident, and I was totally healthy. I had a car accident, and I was brain damaged. In fact, I was diagnosed as being brain dead, and I was on a ventilator. Well, if this living will had been made up, this patient might have said, if I have irreversible condition, that I would want palliative care. In that situation, the definition of palliative care, and I'll just show you that, would be look after my basic needs. You'd probably be in a hospital, so transfer wouldn't be relevant. You would simply maximize comfort and minimize pain. You probably wouldn't use intravenous antibiotics, and you wouldn't do any other tests. So he might suggest, if I have irreversible brain damage and I am unable to recover, treat me with palliative care. And that would be appropriate. And he would fill in the box here. Now, as you can see here, they've made provisos for changing your mind. So if things change in a year, then you can put new, you can fill in new boxes. Usually this is very simple, and you just fill out one box and that's it. Same thing for feeding. They will give you a definition for what feeding is, and they will talk about basic feeding, supplemental feeding, intravenous feeding, and tube feeding. Now, these are difficult decisions. Who knows what intravenous feeding is? Who knows what tube feeding is? But if someone said you had an irreversible condition where you would never recover any useful function, you would never recognize anyone, and you would never be able to eat alone, then you would say basic feeding, which would mean if you could eat, they would feed you, otherwise you wouldn't be fed. And that would be a reasonable decision to make. Cardiac arrest, if you take a patient who has heart disease, lots of people have had heart attacks. Because you've had one heart attack doesn't mean that you don't want to ever be treated if you have another heart attack. And if you're a young person, you have a heart attack, and you come into hospital and you have another heart attack, most people would say, treat me with CPR because I'm young and I want to live. If you're 80 and you've had 4 heart attacks and you have had a poor quality of life and you're confined to a bed or a wheelchair, you might write, I don't want to have CPR no matter what happens to me. So even if it's reversible and I come into the hospital, don't resuscitate me. And that's a reasonable situation for an 84-year-old who's had multiple heart attacks, but not a reasonable situation for a 49-year-old who's had one heart attack. And so this allows you to fill in basically things that are appropriate. Now, Mr. McGee has given you a sheet which is very detailed and goes through a lot of different options for various scenarios. It's one approach. This is one other approach. Both of them, I think, need to be gone over with your doctors because they tend to be complicated and asking questions which you've never had any experience about whatsoever. Does anyone have any questions specifically about this while we're going through it? Okay.
Do you actually have time to sit down with us and explain all this to us?
Well, sorry, do I have time or do your doctors have time?
A doctor has this kind of time.
That's a difficult question. Usually no, but I think that there within the doctor's time there is a slot which is called counseling, and they can allot a longer period of time for that. And if you ask your doctor for a counseling session and you let him know that you want to talk about the living will and that you're going to have a number of questions, he can set aside a half an hour. You can go through part of it, and if you don't finish it, then you come back another time and go through the next part. So time can be made, especially if you've done your homework and you have good questions and you have specific things that you want to discuss. I think that, yeah, it can be done. Especially if your doctor knows you well, and if you do have an underlying medical condition, then it's very worthwhile doing. Okay. Oh, sorry. One should be kept with yourself and your spouse. One should be in your family, your doctor's office, and we're just making preliminary arrangements now that one should be on your hospital chart. Now that the hospital is still working through the legalities of the living will and how we're going to respond to them. Once again, one of our problem is making sure that when people do living wills that they are in an informed will, and it's not just a signature on one of these rather vague things that really, if the patient walks into the hospital and is having a cardiac arrest and I see one of these, without any other information, it's very difficult for the doctor just to stop everything based on a signed piece of paper, especially if it was signed 2 years ago. So we're working through the legalities, and Mr. McGee may have more information on the hospital situation with regard to that.
Is it time
Sorry?
You know, you have one, number 3 there, for the tissue and the spine plan. That would give you the authorization to right away use the proxy and send them.
It would. Yeah.
You
Now,
will have to wait for family or not.
you see, that's another question, and hopefully we'll get some information on the legalities or where we stand legally with that. Right now, as you know, you fill out your license and you put on your license whether you want, and I presume that's a legal document.
You need the authorization or not from a member of the family.
Normally we would try to get that.
But
Yeah.
in some cases, you have a family around.
Yeah.
So can you go ahead or not?
Normally we would wait unless we had family. Unless if it was impossible to get family and we had some type of recently signed document, then on that basis we might go ahead. Usually transplantation does not have to occur immediately. Patients can be supported through mechanical ventilation and what other means till we get authorization to transplant.
But that will not be enough.
We'll talk to Mr. McGee about that, okay, when he comes up, because the legalities, I just don't, right now we're trying to work through that in the hospital and we don't know.
Once you've spoken to the family and the proxy, that's probably the first line of action is to locate the family.
Or my first line of action would be if there was a living will, I would try to contact the family doctor and to discuss his, presuming that he'd been involved with the discussion with the with the patient, and I would review it with the family doctor. And if the family doctor was clear that yes, the patient, this is what they wanted, then we would go on that basis, I think. If we would always try to get hold of family as well. But then, hopefully these are made with the family's knowledge. I mean, we try to encourage that the living will is made not just in isolation by a person, but with a family doctor, with family members, so the family members all know, so that when the time comes, everyone's in agreement, everyone understands what's to be done or not to be done. But just to summarize, if you're thinking of doing a living will, the first thing to do is find a design and a document that you feel comfortable with. And some of these books that Marie has talked about are very useful and work through with you and give you various options to use. Discuss the contents with all those in a decision-making position. So as we just mentioned, your family doctor, your lawyer, your close friends, and your family, and try to get them to understand what you want and have them agree with you so there's no confusion. You should have some witnesses sign the document and try to keep it current at least every 2 years, and so that it reinforces its validity and reliability to us. Copies should be available for your immediate family, your family doctor, your lawyer, and your close friend, and they should be available so that if they're needed, they can be found. And even putting one in your wallet might not be unreasonable. So in conclusion, many patients are aware of living wills, but few actually execute them. At the present, it's a little unclear how much influence they exert on our medical treatment, but I think there is becoming more recognition, and as they become more widely used, they'll become more accepted in the medical field. There's a gap between the recognition and the implementation of the living will. Some of the questions that we've been asked tonight and my hesitation show that there is a certain gap between recognition and implementation. And some physicians are actually reluctant to withdraw artificial life support, especially in view of the fact that there may not be established legal support for these decisions. And Mr. McGee will address that. As it becomes more prevalent, it will become increasingly important in determining treatment decisions for patients. The living will serves as a general guide to the patient's wishes and can always be interpreted and modulated according to the particular situation. The living will is never a substitute for communication between the patient, healthcare workers, and their families. Thank you very much.
I was very interested to listen to Dr. Reid's comments and presentation because although I've been fiddling around with these living wills for a number of years, that was some information that I never heard before, and I'd always wanted to hear it, so that's great. The thing that came up, I think, with Dr. Reid's presentation that I found very interesting was the changes that are happening in the area of living wills and how we're looking at these types of directives. And the changes, I think, are gaining in speed. And so hopefully a lot of the things that were seen as a problem as far as the binding nature of these documents will go away, and they will be able to be binding. I think it's very important to note from a legal perspective right now that about the only thing you can say is that these aren't binding. They are wishes that you wish to have taken into account when you're seriously ill and when you're in the situations that Dr. Reid was describing. But they are not something like other legal documents that can be enforced necessarily. Now that may change, and one of the most interesting things I think about this is that this Jack Bell fellow, and he's an actual real human. I met him yesterday when I picked up this stuff from him down in Vancouver. He's the one who's made up this gray, newer style living will that when I was listening to Dr. Reid, it seemed like it was kind of that middle one that you were talking about there. Yeah, please take one of those, Dr. Reid. Anyway, Jack Bell apparently has enough means to be involved in this issue, and he's established this foundation. His address is right on there so you can get more information, although I tried to get everything that they had available. So he is throwing a lot of resources at the issue, and the legal problem is that we don't have a mechanism for appointing a representative to give binding directions to the medical practitioner. Now, what these documents do is they set up a proxy, and that certainly should be done. But if an argument developed between the proxy and the medical practitioners over what shouldn't be done, with the proxy saying, for example, do not do this, and the medical people saying, well, we want to, the medical people would win. If you were able to discuss it with the medical people, then your wishes would have to be honored as far as not receiving care. So if you're in a state where you can actually direct, then you can give these directions. The problem, of course, is that what we're anticipating here is a situation where you cannot give the directions yourself. That's why you have the document and the representative or proxy to do it for you. And at least right now in British Columbia, that wouldn't be legally binding. It would certainly go a long way, though, because I think that most medical practitioners want to honor these documents. And the information that you were getting from Dr. Reid was great as far as how to go about setting all that up so it doesn't come down to an argument between your proxy and the medical people. That's what you want to do, and your family members. You want to have this all working along on the same wavelength so that it doesn't become an issue. It's just something that's accepted by everyone. Now, there are two developments, however, in the idea of the law and how it affects this issue. And the first one is a case out of Ontario that I just found out about from Jack Bell, and I haven't had a chance to look at it. But in that case, it was a relatively common case, but apparently the judges in Ontario who heard the case made an unusual decision. And what happens so often is that a person who is like a Jehovah's Witness, who does not want, say, blood transfusions or something like that, is brought into the hospital, a young person, not someone who's terminally ill, and a decision has to be made about whether to give them the blood transfusion. And in the case out in Ontario, the young woman came into the hospital. She needed a blood transfusion in the medical way of looking at things. The nurse found in her purse a Jehovah's Witness card. I guess they have cards, I don't know, that say, don't give me anything, and showed it to the doctor, but the doctor went ahead. He said, well, it's not signed, and he went ahead and gave her a transfusion. She recovered, she was fine, and then she sued the doctor for assault, because that's what he had done. He had touched her without permission and without her consent. She was successful, and the judge suggested that you shouldn't be given medical treatment that you don't want. Now that was a good precedent, and it has been backed up a little bit by the province of Nova Scotia, who wrote a very, very short act that allows you to appoint another person to make that decision for you, and that person's words would be legally binding, and that's what's missing. That's the missing part here. So for that lady who was in Ontario, another friend of hers or her proxy could have come in then and said to the doctor, even without a card in her pocketbook, she shouldn't get the blood transfusion, and if the doctor would have to go along with that. So that's what we're missing in BC, and that's what we need, is a short little statute that allows the living will document or something like this to appoint a proxy who can actually make the decision that they've discussed with you beforehand available to your medical practitioner, so that you won't get what you don't want. So right now, though, we don't have that, and I think that's very important to keep in mind. I definitely think that all these steps should be gone through, and that's why I was so happy to hear Dr. Reid, because I think that he's right in that you've got to get your own doctor involved. Maybe even first. I don't know what the order would be, your family or your doctor first, but both of those groups have to be involved. And if you can bring them around to your way of thinking, then you're on the right track, and then you're going to get what you want in the end. So it's not the type of deal where, like your legal will, the will that you use to dispose of your property, which is a binding document, is something that you do in secret, maybe, and you don't tell anybody that you're leaving the porcelain cats to Sue and the porcelain dogs to Bill. You let them guess. But in your living will, you want to go about it in a completely different way. This is something that you want to be very forthright about. You want to discuss it thoroughly with your family members, because they're the ones that are going to put the pressure on the medical people to either take the one step or the other step, as in Dr. Reid's example, where the two children had different ideas. So you want to resolve that with your family, whether that be your children or your parents or your spouse or the people closest to you. You want to get that really carefully worked out. And it seems to me that you might want to do that after you have worked out the more or less details of the medical part of it with your doctor. And I think that Dr. Reid was giving some very good advice as to how to work it out with your doctor logistically, as your question was addressed to him about where do they find the time. I was wondering that too. Where do they find the time in their busy schedules? And his suggestion sounded very good. So you want to work it out with your family, and you want to work it out with your doctors. And then you're almost there, because you've got all the people who are going to be the key players when you're very ill, alerted to what you had in mind. And if at the same time you have some legal document, so that, well, if not, okay, I take that back, some document, not legal document, but document, that is official in the sense that we can tell by looking at it that this is what you really had in mind, these are the people that watched you sign it, and these are the people that you discussed it with, then the medical practitioners will feel a bit more comfortable with trying to follow these directions, because of course there's the other side to this whole coin, which is the fear, and one which I sympathize with, that someone will come up later and say, well, why didn't you take heroic measures with my mother? And if you're a doctor, what are you going to say to that? You've got to have all the backup necessary for that kind of a situation. So if you follow the steps that were set out by Dr. Reid as far as talking to your doctor, and if you really in a detailed way, deal with this with your family, so everybody knows what you have in mind, you're probably in a pretty good position. Now, a part of all that, from a legal point of view, is what do you do with this document? And I think Dr. Reid said, keep one with you, try to get one into your medical file. That's very good. And you should probably also, with this document, give it to your family members so that they have it, so that it's available. This is not something that you want to be finding after you're dead. This is something that you want before you're dead, to be right out there if you're sick. So we're in a transitional period right now, and it's clear to me, just by looking at the difference in the materials from 2 or 3 years ago and now the new Jack Bell materials, that things are moving ahead in the direction which will make it more possible for people to use these documents and pieces of advice to get the kind of treatment that they want. But we're still not quite there yet, and it's, as you can tell from the Sue Rodriguez case, it's a tricky point. And why is it a tricky point? Well, I think that from a legal perspective, the reason is that none of us want to find ourselves viewing a person who's been put in a situation where they have been rubbed out by the use of this kind of device by greedy family members or people who are just tired of having them around. So it's a balancing act between the desire to protect sick people from being taken advantage of and being eliminated, and to protect the wishes of the individual. So you've got to really make your wishes very clear. And what I've given to you is a bunch of different things. Some of them are useful and some of them aren't, probably. The first one was the, almost word for word, the earlier type of general instruction, a living will that Dr. Reid discussed. The one thing I liked about that back when, and it looks like this. It's just a white sheet with living will written in like a medieval script up at the top. It has this paragraph which I always thought as a lawyer was kind of a nice one for protection. Down at the bottom it says, in accordance with the above paragraph, I hereby direct that any cost arising out of any legal action taken against one or more of the above mentioned parties, and that would be all the people involved, family, physician, clergyman, shall be borne by my estate, and further direct that should any judgment be rendered against one or more of the said parties, that such parties be indemnified and saved harmless out of the proceeds of my estate. Now, I like that clause in there, because I think what that means to people who want to argue about what's been done is that it's not going to cost the people who are trying to follow your wishes anything. It may deplete whatever you're leaving behind to the point where there's nothing left, but at least the people who are trying to follow your wishes aren't going to be left with a financial burden for doing so. So I kind of like that clause. I noticed that that's not in the Jack Bell will, and I don't know why. I didn't get a chance to talk to him about why that wasn't in there. But besides that, which is, I think, a fairly handy thing, although maybe today there aren't these battles developing. I don't know whether people actually contest the type of medical treatment that was given to their family members. Maybe that's a hopeful sign that it's not happening. Then the Jack Bell will, which is on the gray sheet, is kind of like the more particular will that, living will that Dr. Reid was talking about. It has a bit of choice as far as things that you want to either have or not have. And he was reading through those, and it's the same on this one. So that's a bit more particular. And then I gave you out this long sheet. I don't know where this came from. Somehow this, a few years ago, just drifted into my living wills file, and I can't remember where it came from. But this one is, I think, something that you would want to go through with your doctor, because I wouldn't know what all these things were if it was me trying to fill it out. And I guess we would hope that if you had gone through this medical directive and it was attached to your official looking living will, your family and physician would know pretty much how you felt about almost everything that was going to happen. And therefore they wouldn't be put in a position of making difficult decisions for you. So this might be handy for you, the long sheet. It has a lot of different situations and check marks. I think maybe this came from the United States, because one of the terms that you can somehow associate with the United States is this idea of a durable power of attorney. And that's more or less what's happening in Nova Scotia. They're allowing people to make these durable powers of attorney. This may have come up from the States.
Pardon me, what does that mean?
I don't really know. I think what it means, the way I understand it, is that I really don't know. I just better leave it at that. Because one thing that you may also want, if you're getting quite ill, is to give someone in your family a power of attorney, just a regular power of attorney, to deal with your financial matters and your legal estate, more or less, all your business matters and paying your bills and that type of thing. So I don't exactly know what the difference is between a durable power of attorney and a regular one, except that the durable one seems to always come with the living wills from the United States. So it must have special meaning down there. Now, another thing that I got from the Jack Bell Foundation was the answers to questions about the living will, and these are good. I think these are sort of a useful thing that maybe this is the type of thing, this sheet is the type of thing that you can give to your family members to look at if they're wondering about what you're meaning when you're talking about starting one of these living wills and getting it filled out. So it might be handy for that. It seems like most of the questions were answered. The one thing I don't like about this is it kind of tends to imply that the doctors would have to follow your living will, and I don't think you can go that far quite yet. But it is closer to what I would consider to be good advice as to the fact that we haven't had a lot of lawsuits against medical practitioners who have followed them. I think that that's probably true, which shows that we're growing as a society. And then the Jack Bell people have also put out this one, which is the 10 steps to making a living will. And that can kind of help you as you balance between the one form and the more particular form. And I really think they should probably go together, and maybe we should ask Dr. Reid whether that's his view, that maybe it's the long one connected to the short one that would be best. And then as long as you keep it in a place where it can be found quickly and easily, I think you're getting onto the right start. And that's about really all I have to say from a legal perspective, because this really isn't a legal question. This is something that touches on the law, but as of yet, we don't have enough law to make it legal. We're just trying to balance things out a little bit and avoid trouble with the law. This is more of a preventative legal thing than a actual legal question.
The legal boundaries, is this provincial, national?
Provincial. The provinces are in charge of health. So,
why Ontario, Nova Scotia have...
and civil rights,
Right.
which would touch on it too.
Oh,
They're all different. Except as far as I know, Nova Scotia is the only place where it is legal to appoint a proxy who could give binding directions on your behalf.
How in the world do ordinary mortals go about getting that to happen?
Well, I'm not paying a lot of attention to this issue and how it's moving through society, but it seems like it's moving along quite nicely on its own, probably with the help of Jack Bell and others, and with the growing awareness of...
So there has to be a lobby group of some kind as well.
I would think so, yeah. Maybe Dr. Reid knows something more about how that's moving on. I don't know. I think that as the province tries to grapple with the increasing healthcare costs, it may be seen as a tenable alternative to what we've got going now. Of course, on the other hand, nobody wants to be seen as eliminating unwanted people,
Yes.
older people or poorer people or anybody. So.
What's the status of all this in the states? Is that state by state, or do you know?
No, yes it is. It is a state-by-state thing, again, down there. I think that in most of the states, you're probably able to do this and appoint a proxy who can make these decisions for you. That's the key thing. You can always make up the wish list, more or less. But if you're lying there and you can't speak or blink or do anything else, you can't get those wishes across.
Mm-hmm.
And what the key thing seems to be being able to appoint a friend or someone that you trust to speak for you and be binding.
So I'd like to thank you both for coming out and sharing this information with us. It's been really worthwhile, and although there are obviously a lot of gray areas, I think what we can take home tonight is the ability to go and make our own living wills and to share that process with others as well as we can right now. So thanks a lot for coming out and spending your time. Thanks, Dr. Reid and Kenyon McGee, for sharing that information with us.
Thank you. Thank you.